Welcome once again to immunity. Today we are going to look at the adaptive immunity, its mechanism, and also some clinical examples. And so when we say the adaptive immunity, also known as the acquired immunity, and it is the resistance to infectious agents that the human body acquire whilst it develops. And usually it's the second line of response. As we saw before, once the innate immunity fails, the acquired or the adaptive immunity takes over. We have two main types of the acquired or adaptive immunity. We have the active and the passive. And so we have active um, acquired immunity, then we have passive acquired immunity. When we say active acquired immunity, it is the resistance that an individual develops as a result of an antigenic stimulation. And so once you are infected with an infectious disease, the immunity that you develop is what we refer to as active immunity. The passive, on the other hand, is the resistance that is transmitted passively to a recipient by a ready-made, substance. And so this one, we provide the immunity by way of vaccination, and so we can easily give it to a patient uh, because we formed it outside of the patient's body and we introduced it into the patient. And so we say it is passive. It may also be given to the patient from the mother, and so we are going to look at all of this in detail. Now, when we look at the active immunity, like we said, it synthesizes antibody and the production of immunologically active cells, and they develop the humoral or cellular immunity. It forms, or we have the latent period or the negative phase. The latent period is the period that it is required for the activation of the adaptive immunity, whilst the negative phase is the period whereby we have reduced form of immunity, and it is when the antigen or the disease causing agent combines with pre-existing antibodies, and so it lowers the amount of antibody or the amount of the antigen in circulation. Now we have the secondary response when we look at the active immunity, and this is when someone has previously had an exposure to an infectious agent. And so we say when the person gets repeated exposure of the same antigen, then it will elicit a much quicker and abundant response anytime the person is exposed to such an infectious agent again. Now, the active immunity has immunological memory. So when we say it has immunological memory, what it means is that it is able to retain the memory of the previous exposure. So once you get an exposure, the body is able to keep memory of it. And so anytime you have this infectious agent coming into the body again, the body is able to fight against it because it has already produced antibodies against it when it first got exposed to it. And we say the active immunity is more effective and better, or provides a better protection than the passive immunity because you produced the antibodies yourself. When we look at the active immunity, we have active natural immunity and active artificial immunity. So when we pick active natural immunity, it is the clinical or apparent infection by a microbe, and the immunity is usually long lasting and also is pathogen specific, and so it's able to provide protection against specific diseases. And so most adults have active immunity against poliovirus because they may have acquired the infection whilst they were growing up. And usually, this active natural immunity is lifelong, or it provides lifelong immunity, such as we have it in viral disease such as chickenpox or measles. Once you have chickenpox for the first time, you have a lifelong immunity because your body has generated antibodies against them. We also have viral infections such as influenza and other common cold, which recur after a few months or a year. And this is because there is lack of immunizing capacity of the virus, as well as the antigenic shift and antigenic drift of the influenza virus. And so the body is unable to, provide specific immune response to them. Now, still on the active natural immunity, it usually follows bacterial infection. And so, immunity following bacterial infection is less permanent than that of a viral infection. We have a term we call premunction. And what it means is immunity to reinfection lasting longer until the disease remains active. And this is usually found in typhoid fever. Now, the other part is the active uh, artificial immunity. And this is usually immunization with vaccines such as the attenuated vaccines, killed or fragmented microbes, and also toxoid or antigens from recombinant DNA technology. And so, with the artificial form, we are providing vaccination to the individual. And these are the forms that we give. It may be attenuated by weakening the microbe, or we can kill the microbe or use the pieces of the microbe to form vaccines, or sometimes the toxoid and also antigens, which we form from the recombinant DNA technology to inject individuals in order to, generate immune response by producing antibodies. Now, with the active artificial immunity, uh, we also have the booster doses. And when we say booster doses, it is when we repeatedly vaccinate individuals, after they receive the primary vaccination. And what happens is that this repeated vaccination leads to a prolonged immunity of the person. And so, examples of the um, infections or diseases which may require booster doses. We have the flu vaccine, that is the influenza, shingles vaccine, that's the zoster, then hepatitis A, hepatitis B, tetanus vaccine, diphtheria, pertussis, and also Haemophilus influenza B. In all these conditions, when we give the vaccine, we need to give booster doses of the vaccine. Then we also have the live vaccines. So the live vaccines examples may include that of measles, mumps, rubella. Then also we have the rotavirus, the smallpox, chickenpox, as well as yellow fever and cholera. These vaccines are live vaccines, and they may be contraindicated in pregnant women. There are other contraindications to live vaccines, including, aside the pregnant women, including those with reduced immunity or immunosuppressed patients. You wouldn't want to give live vaccines to them. The list is non-exhaustive. There may be others. And so the live vaccines, or the active artificial immunity, initiates the infection without causing injury and disease. So when we give it, uh, the, the person may initially show signs of the infection, but the person may not be in an infectious stage. And so it doesn't cause any injury to the individual. We administer it orally. For example, we give the Sabin vaccine for poliomyelitis, and also it may be administered parenterally, talking about the measles vaccine. So these are examples of live vaccines under the active artificial immunity. Then we also have the killed or inactive immunity. And what we are talking about here is these ones are comparatively less immunogenic as compared to the live attenuated vaccines. And so their protection lasts only for a short period because they are killed or they are inactivated. And also, they have to be supplemented by repeated booster doses because of the short period of protection. We also administer them orally, though it's not preferred. We also give it parenterally by enhancing its effect when we add adjuvant to it. Examples of the killed or inactive vaccines, we have the inactivated polio vaccine, that's the IPV. Then we have the whole cell pertussis, which we use in whooping cough vaccine. Then we have the rabies vaccine, hepatitis A vaccine, cholera vaccine. And note that the cholera vaccine may be both live attenuated or killed vaccine. Then we have the passive immunity, or the ones which we do not produce by ourselves. So we said the passive immunity may also be natural or artificial. And so this form of immunity is passed from mother to baby. And so it's transmitted basically through the placenta in humans. For example, we have immunoglobulin A antibodies in units being delivered to the babies through the colostrum. Then also we have, even in utero, the synthesis of immunoglobulin M from the 20th week of gestation. And this is what the baby is born with, and it provides protection, against infections in the neonate. During this period, there is immunological independence. That is, the baby depends on this IgM that it got from the mother, at least for the next 3 months. And so, until the next 3 months, the baby may be protected from various infections until the baby begins to produce its own antibodies. It is because this is why we realize that in young or in neonates, they may not be, or they do not usually get infections. And the infections in neonates usually occur after 3 months of life. This is why we advocate active immunization of pregnant mothers, especially with the tetanus toxoid, for example, which we recommend during pregnancy so that its protection for the unit may be enhanced. Now, still on the passive artificial immunity, so we've seen this one was the passive natural immunity. Now we are talking about the passive artificial immunity, and this is the immediate but short-term immunization following injection of antibodies such as the gamma globulins, which are not produced by the recipient cells, and so they are developed in another individual or animal, and we inject it into another individual. An example is the rhesus immunoglobulin, which we give to the mothers who may be rhesus negative and may be having a rhesus positive babies. So this is an example of a passive artificial immunity. And the agent which we use for this passive artificial immunity includes the hyperimmune sera of animals or human origin. We have the convalescent sera as well as the pooled human gamma globulins. When we say convalescent sera and pooled human gamma globulins, we are talking about the serum from a patient who is recovering from an infectious agent. So, for example, if the patient had COVID-19, the person is recovering from this disease, we say the person is having high levels of specific antibodies against COVID-19. So, we can take this serum from this patient and, you know, infuse it into another patient who is at risk of getting the infection to protect the person from getting the infection. Then we have the pooled human gamma globulins. Um, what it means is the serum from a healthy, individual. We take the blood serum or the serum from healthy individuals, and these healthy individuals their serum contains lots of pathogens which are prevalent in the region to cause a specific disease. And so, if you live in a community where there is lots of specific disease process, once people are infected and are healed afterwards, they develop immunity against such, infectious disease. And so, we can take their serum and use it to, inject other people who may be at risk of such infections. And this was used extensively in the past for viral hepatitis A and also in some immunodeficiency disorders. But there are some disadvantages, such that the gamma globulins may aggregate in the veins and they may cause anaphylactic reactions due to complement activation. And so we usually give it intramuscularly only. Then we also have the chance of getting blood-borne infections such as hepatitis B, C, or even HIV and other infectious diseases when we undertake such processes. Now, the other one we use is the hyperimmune serum, and an example is the antitetanus serum, which is derived from the hyperimmune equine, that's the horse, and so it provides temporal protection and also its protection. It's quite long lasting. Yes, and we also have others which we use in the hyperimmune serum. So we may have for the anti-gas gangrene, we have the anti-botulinum serum, and also the anti-venom. These are all forms of hyperimmune serum that we can use. Then we have combined immunization. With a combined immunization, what we mean is we are giving both active and passive immunity to a patient at a particular time. And so, what happens is, for example, you can give tetanus immunoglobulin in one arm and tetanus toxoid in another arm, followed by a full course of the tetanus toxoid. And what happens is this provides immediate protection to the patient. It's usually a passive form of protection. And so the tetanus immunoglobulin provides the necessary protection till the active immunity is able to take place. And this is the essence of giving combined immunity, such that the tetanus immunoglobulin will be given enough time for it to start working. Then we have what we call herd immunity. And herd immunity is also referred to as community immunity. And it is the direct protection from a contagious infectious disease that happens when a population is immune either through vaccination or immunity, which is developed through previous infection. And so, in essence, what we are saying is when a large part of the population in an area is immune or have antibodies to a specific disease, such that the few vulnerable people in the community are protected from this infectious agent. We refer to it as herd immunity. Now, herd immunity is usually achieved through infection rather than vaccination. Then, if it is unchecked, infections can lead to serious, morbidity, mortality, as well as overwhelming the health system if we dwell so much on herd immunity. And um, the herd immunity may be reached when enough people in the community are immune, such that the pathogen can't spread from one person to the other. Because if A is having the infection and B and C are all immune, it means the infection cannot spread from A to B to C and even beyond. Yes, and so this is the idea of herd immunity. Now, it has its own challenges. Uh, the challenges we face with herd immunity is that the nature of the infectious disease may not uh, make protection from herd immunity possible. And so the more the infectious process, the greater population immunity needed to have herd immunity, possible. We also have other challenges such as access and availability of vaccines to provide immunity to larger populations, and also we have sometimes superstition and misinformation about the infectious disease, and also concerns about the efficacy of the safety of the vaccines, and also the unusual or rare side effects of the vaccine and the costs involved in procuring these vaccines, as well as even how to store these vaccines. These are all some challenges we may face when we talk about herd immunity. Last but not least, we can also talk about the limited shelf life of some vaccines, sometimes only up to about 6 months. For example, if you look at the Oxford and the AstraZeneca vaccines against COVID-19, it has this short, shelf life. And so storing it becomes a problem, and using it to achieve herd immunity also becomes a problem. Also, we have the nature of some viruses. If it's seasonal, then repeated vaccination is going to be, what we require. And so, which may also be uncomfortable for some patients. So these are some of the challenges that we may have with, herd immunity. Now, um, the advantage that we may have with herd immunity is that it is vital in the control of epidemic disease such as the diphtheria, pertussis, and, tetanus, and also um, vital in the elimination of certain diseases such as the smallpox, which we used. Then also, epidemic is likely to occur with low herd immunity, and so once we have very few or a very small amount of the people immune to a disease, the likelihood that the disease may spread among the population. So, this is all that I have for you. Thank you very much. Bye bye.